Welcome to COVID Talk. Today I have the pleasure to have with me Dr. Heidi Stensmyren. Dr. Stensmyren is the president of the Swedish Medical Association, and she is a physician for anesthesiology and intensive care, and that puts her right into the middle of the pandemic action in Sweden. Good morning, Dr. Stensmyren.
Good morning, Otmar. Good to see you.
Up to now, Sweden has about 7,693 cases. That is the number of this morning of confirmed infection with COVID-19. There have been already close to 600 people dying in Sweden from COVID-19, which is quite a lot for a country of 10 million people. Now, what makes Sweden very interesting and different from most of the European countries is that Sweden has chosen a different way on dealing with the pandemic. Sweden has not gone the route down to lockdowns and very harsh restrictions, but still tries to deal with the pandemic very openly. So how do you see, as an acting physician in Sweden, the situation right now, Heidi?
Well, of course, the situation is difficult. We have we do have restrictions, but my concern is mostly in healthcare system, how to deal with all the cases, the cases in hospital, the lack of hospital beds, and so on. So there are several perspectives as a physician and a president of the Swedish Medical Association here. To start with the healthcare system, I'm of course concerned, but we have managed to increase the number of beds significantly, which is good. We do have a margin when it comes to ICU beds and ICU capacity, even in Stockholm. And Stockholm is the worst hit place at the moment. My concern is about the beds in other units, internal medicine, geriatrics, infections medicine, and also the other care, because it's difficult for people to get into hospitals. We have many patients staying at home, being sick at home. And of course, the healthcare professionals. In my clinic, we have 10 colleagues at home being sick at the moment. And we have around 20 to 25% of staff home sick. And we have a lack of testing of personnel in the hospitals, which means we have a huge number of unidentified cases. So that's the concern here. About the Swedish strategy then as a physician. So yes, we haven't closed our borders. We have the schools open, and it's about timing. I believe Sweden started fairly late, what we have seen in the numbers. It did spread around in the society before the authorities acknowledged it. So it was a widespread before strict restrictions were put in place. We do have restrictions, but they are expressed very in another way than in other countries, which means that even with restrictions, people do move around much more than in comparison to other countries. And the restrictions are coming in late. For example, last week they decided to abstain from travels to Stockholm and internally in the country, which was fairly late compared to other countries. And also the test capacity, the scale up of test capacities is coming late. So we're sort of running a bit behind the other ones, you can say, and the restrictions. On the other side, what our authorities and also we see, this is not only about COVID-19. This is about the whole health of the system, of the healthcare system, which means we need to see to other parts of healthcare, cancer, surgery, taking care of heart diseases and so on. So we're trying to do it as a whole and not only focus on COVID-19. This is also about the society. So the Swedish society model builds on that we can provide welfare. It builds on that the economy is working. And with a total lockdown, that would be more difficult. So we're trying to lock down thoroughly, but keeping many of the businesses still going. If that will be if that will prove to have been successful in a year, 1 year, 2 years, 3 years, that is to see.
So you have a very long perspective for this pandemic to go through the country. So you expect that this pandemic will go on for months, not for weeks, obviously.
Yes. We have a long perspective in this, and that will be the challenge. I'm working now in the ICU unit, and it's quite heavy because we have masks, and I just went out, took off, because otherwise you wouldn't see me and all the things. And it's going to be for a very long time. And to this, all our other patients that have been waiting for their cancer treatment for other things need to get treatment soon. So that's going to be difficult for us. And yes, Sweden see this in a long perspective, and they will wait in not only the deaths in COVID-19, but all the effects on health, which is a different approach from many others, focusing mainly on COVID-19.
I can only agree. The discussion about what is being now distracted from other parts of healthcare, which also is necessary and for some patients certainly essential, is now being discussed in other parts of Europe, because what we see is that certainly necessary healthcare is being delayed or not being given, and that is a question as well, and may produce also other casualties or damages which we are not accounting for right now. Now, does Sweden reserve the option to step up with restrictions? Is that also an option if you see that you cannot contain?
Yes, it is. And the government put a law on this yesterday, and they pushed it through the parliament, that the government should be given the right to overrule the regions to put more restrictions on. Because in Sweden, Sweden is a small country, 10 million inhabitants. We have 21 regions with separate healthcare systems, and they cannot be overruled easily. So now, yesterday, the government got this new law making it possible to step up. But I do not think they will do a complete lockdown. And Denmark and Norway is signalizing that they're going to open up again in a week. So Sweden will probably not do a very harsh lockdown. I don't think so.
Yeah. Now, is the intensive care capacity already at a point where you have to do triage? And if yes, how do you decide on triaging?
We do have capacity still. In Stockholm, the worst hit place, we have about 20% margin in the ICU beds, and we are still increasing the number of beds, but we are also changing the level of ICU. We have orthopedic surgeons and gynecologists in the ICU units, which means staff that are not used to that, to work here. So we have a sort of a more pragmatic level of care in the ICU unit, but we do have margins. Where we have difficulties are the other one, internal medicine, the emergency room where the people are coming in. There we have a tiny margin, but we do have a margin. And so that's good, but the difficult issue for the professionals is the triage, because they are soon going to make a very harsh triage if it's going on. We are expecting it to continue to increase for the coming 2 weeks in Stockholm, which is going to push us to the limit. And our authorities has put up a triage, which is difficult. We will have to deny people intensive care that we would have given intensive care, and it's going to be very, very difficult.
And will this triage be based on an age limit, or will it be based on medical criteria?
Of course, we have participated in this, and there will not be age, and not chronological age, but biologic age. So the physician will look at the biologic age and all the other considerations and the condition of the patient, and also the life expectancy. So we have 3 levels. We will look at the life expectancy as well. And this is important. And we have had our ethical, the WMA ethical guidelines, of course, that we have weighted in. So we have this aligned. But still, there has been discussions about age, and we are opposing that very firmly.
I think it's very important that from a medical ethical point, we always look into what is the medical possibility to treat. And very often this will, of course, correlate with age. I think there is no doubt about that. But age as such is certainly not a good criterion to go by with that. In most of the other countries in Europe, we have seen shortages with material. Is that something that you have seen as well, PPE material for your clinics?
We have huge problems with that. We have a margin on delivery at about 48 hours now. In some clinics, 24 hours. So we are totally dependent on getting new deliveries. This is a huge problem for us. And we are also even making our own covers and shelters. So, and colleagues are very concerned about that, running out of material. We also have concerns about medication that we use in the intensive care, because we rely on supply from fabrics in Italy or China. So we have already prepared to use alternative medications. The personal protective, the equipment, is the most limiting factor, I would say.
Heidi, thank you very much for this talk. I wish you very much success with your work, and thank you for all the work you are doing for your patients and for the people in Sweden there. Thank you very much.
Thank you, Otmar.
Bye-bye for that.